Good morning, all delegates, and good morning, all doctors who are physically present here. Warm welcome, warm good evening to all of you and to the eminent faculties who have been joined today. On behalf of Lloyd Healthcare, we have been initiating the program called as the Med Intelligence Meet. Reason being, the ESC guidelines has been recently published, so thought about to reach this scientific endeavor as quick as possible. And just to inform you to all the delegates who have been joined right now here, this program is getting live broadcasted across India, and more than 2000 doctors are right now waiting for this particular program. So that's the reason we have been getting start. We're actually 15 minutes, 20 minutes delay, reason being Navratri is been going at Delhi. So most of the doctors are being stuck up at the traffic. That's the reason we are trying to reach. But I think we should not wait the people who have been joined online. That's we have been starting the program right now. So we at Lloyd Healthcare, we are actually forefront in terms of scientific endeavor, what we have been looking after it. That's the reason we have started with Med Intelligence, a scientific meeting, physically plus virtual. So just showing a corporate AV to all of you because Lloyd Healthcare is just shaping up in India. So we are starting just an introduction for the Lloyd Healthcare corporate. And then later on, we will go to the program agenda. So just I'm switching on. Requesting team, please switch on the video and audio.
Every heartbeat is the rhythm of tomorrow. When science and care unite, hope begins. Healing is not alone. It lives in harmony. 2,000 people, 500 crore strong. One heartbeat of care. Politeness that comforts as deeply as care. Transparency that builds bridges of trust. Role models who inspire a new way forward. 1.5 crore lives, 20,000 specialists, one shared belief. Business Excellence Award Pharma Company of the Year 2023, Outlook Business Spotlight. Emerging Pharmaceutical Company of the Year 2024. International Book of Honor, House of Commons, England. Lloyd has always been at the forefront of driving scientific upgradation for healthcare practitioners. Our collective heartbeat became a global voice of hope, innovation and compassion in perfect synergy. 1,000 crore by 2030. Progress is harmony, science and humanity as one. Lloyd Healthcare, where synergy creates a new way of life.
Thank you so much. What Lloyd Healthcare is having it. We are just shaping up, as I said, in the entire India. We are having one manufacturing plant, even R&D center at Tirupati. That's what we are being south dominated and prominently. So going ahead without wasting time, we will go for the program agenda, what we have been discussed. I think we have, everybody knows about it. We have a chairperson for our program today. So I'm just quickly going to the introduction of Dr. Meena Chawra. I think well-known personality in if I talk about Delhi. She is visiting consultant, Department of Internal Medicine, Sri Gangaram Hospital, prominent diabetologist in, if I consider the diabetology as in therapy, decades of experience in managing patients pre and even post transplant, renal transplant kind of a scenario. Treasurer for Delhi RSSDI for the next term and executive member of Delhi Diabetes Forum. Faculty of various national and international conferences and even in research and trials has been a lot. So I'm requesting Deepak, please come forward. Felicitate ma'am on behalf of Lloyd Healthcare.
So I'm lucky to have an introduction which is perhaps 25 years old. So it's my proud privilege and honor to welcome Professor Dr. S.C. Manchanda, who's a teacher, and he's teacher of teachers, and he's the 8th DM cardiology in the country. So big round of applause for Professor Manchanda. And sir is a Padma Shri awardee. He received the Padma Shri in 2004. And more than that, I always regard him as a philanthropist, and also he encourages people to exercise. So in our area, New Rajendra Nagar, for the past 25 years, relentlessly sir teaches yoga, and I'm so proud to introduce him today because no one can do that. He's actually changed the, where we just talk about lifestyle modification, but sir actually practices what he teaches. So again, my honor, sir, and he's presented over 450 scientific papers in various national and international medical journals and original research work in the field of high altitude problems and lifestyle. He's done studies on yoga. So, sir, over to you now to moderate today's session. We have 3 speakers. Yeah. So we would like to felicitate him. A big round of applause for him. So the audience is going to increase because there's a lot of traffic. So we have, and Professor J.C. Mohan sleeps at 10 p.m. He again practices what he preaches, early to bed and early to rise. So I think we've started the program in time because we have 2 stalwarts in front of us, Professor Manchanda and Professor J.C. Mohan. So,
well, friends, it's an honor to moderate this session, a very important session which will tell us the current status of cardiology. This is the best of ESC. European Society of Cardiology has every year a yearly meeting in which a large number of trials are discussed which can change our clinical practice. These are called late-breaking trials. And there are a huge number every year. These trials, of course, do not come in the textbooks for a long period of time, but I think this is the state of the art of cardiology, and I'm sure all of you treat cardiology patients, and we are going to discuss in this session several of these studies which will have impact on the clinical practice and all that. There are a large number of them, and the European guidelines are very close to Indian guidelines. Actually, the American guidelines are not liked by many of the Indian cardiologists, and therefore I think the European guidelines, especially the dyslipidemia guidelines which will be discussed later, are similar to what Indian guidelines are and all that. And to address these so-called late breaking trials, we have the 3 most eminent cardiologists of the country. These are absolutely the top cardiologists. They are excellent teachers, and they give the message in a very crisp and a short manner and all that thing. We have, of course, 2 of them already here. Dr. Peeyush Jain has just come. No, you don't have to. And Dr. J.C. Mohan is here for a long period of time. Who would like to start with J.C.? Would you, or? Yeah, I think J.C. has been waiting for a long time, so he will start. He does not need any introduction. He has been a professor at G.B. Pant Hospital. He has been my colleague at All India Institute of Medical Sciences, and I think he is, I call him thinking cardiologist. He thinks out of the box, but I think he is an excellent teacher, and as you will hear from him, he is going to talk about some of these studies which will have a big impact on clinical practice. Yeah, J.C. Mohan does not need to call this. It is written what is there. He has been my colleague and one of the, I call him the top cardiologist. He is a holistic cardiologist. People do interventions, they do non-invasive, but he is leader in, of course, echocardiography. He is one of the best in the country, in the world, I would say. He is one of the best in the interventions also. And above all, he is an excellent human being and an excellent teacher and a clinician. So, J.C., please.
Good evening, ladies and gentlemen. Thank you, Professor Manchanda, Dr. Mrs. Chopra, Peeyush. I have an unusual task actually. Neither these are guidelines nor these are late-breaking trials. I mean, at least the first topic is not on late-breaking trials. I have been tasked to talk about complete AI-enabled echocardiography interpretation with multitask deep learning, and what has been presented in this ESC 2025, and I was there for all these 4 days. So the topic is complete artificial intelligence enabled echocardiography interpretation with multitasking deep learning. One of the important things I realize is there is no place better than echocardiography where artificial intelligence is needed. And the reason, if you look at the city of 20 million people, you can't even count 20 qualified cardiologists who are dedicated echocardiographer. You cannot count 20. I bet you will count hardly 10 people. That is one qualified echocardiographer for 2 million daylights. And that is the situation. So if you can have acquisition, interpretation, reporting by artificial intelligence, that would be a big boon for at least echocardiography. A lot of actually things were discussed in ESC 2025. I think the most remarkable thing was this this algorithm, which is actually a AI enabled algorithm called pan echo, and I will talk about that in a while. But let me take you through some of the basic aspects. How do I do an echocardiogram? How do you do an echocardiogram? You first start with a transducer, put on the chest, and you say, how is the image quality, what we call as acoustic window. It could be fair, it could be excellent, it could be suboptimal. You start with that image quality, and then you identify the views you are getting. Obviously, you know how to obtain views. You get views are identified. Then from those views, you make measurements. After you make measurements, you detect abnormalities. So after you have detected abnormalities, you will report these abnormalities, and then you will give suggestion to the treating physician what should be the next line of action. All that thing is a part of what you call as echocardiography. So you are on the machine for one case for roughly 40 to 45 minutes. That is what is the recommendation of the British Society of Echo, and that is also a recommendation of European Association of Cardiovascular Imaging. Each case takes about 40 to 45 minutes. Then you do some offline analysis of whatever you have acquired. That will take you another 15 minutes. And then you will prepare a report. It will take you about another 15 minutes. And then you will talk about diagnostic probabilities. So this is 1.5, somewhere 1 hour and 15 minutes job. That is why the British Society of Echocardiography and ESC says no individual can do more than 8 echoes per day, and no machine can do more than 8 echoes per day. You understand? So obviously this is not cost effective. Certainly not cost effective in this country. Certainly not cost effective in this country, where of course place like GB Pant might be doing 200 echoes in one machine. So clearly artificial intelligence is needed, because otherwise we'll be doing a shoddy job. So the limitations of conventional echo is it is highly operator dependent with regard to quality and variability. So there is a large variability and very variable quality, and for you to become a skilled operator, it needs intensive training. That is a major issue with echocardiography. The other thing I showed you, the data, is time consuming, and there is a subjective interpretation. So there is a lack of diagnostic consistency, and that is a major issue of all imaging techniques, much more of those imaging techniques which are operator dependent like echocardiography. What can you achieve by AI enabled automatic echocardiography? Hopefully it makes the echocardiography more objective, precise, and often with subtle predictive information. So what are we trying to get by emulating human cognitive function is expert level diagnostic accuracy every time and everywhere. It will minimize human error, hopefully, and also reduce the inter-operator variability, and also it will give you predictive insights. Okay, that is what the whole basis is. So let me just actually yesterday I actually scanned this individual who is 44 years old with a body mass index of 33, and he is normotency individual. So he was a doctor's nephew, so he was sent to me. I just want to show you how AI actually would work. So you have actually with the single probe, you put it the transducer at the apex. At the top actually you can get all the three views simultaneously, apical views. These are the every 60 degree there is a view. You don't rotate the probe. That is artificial intelligence. So you get a triplane and you get three pictures. Good enough. Of course it saves time. That is because of artificial intelligence. Instead of actually scanning three times, you moving the probes 60 degree three times, the machine does automatically. So you get three planes, 4 chamber, 2 chamber, long axis view. Good enough. Now what were we doing earlier? We would trace actually these cavities from bottom to apex and endocardium to get volumes, and then of course from volumes to derive ejection fraction. So what does the artificial intelligence do? Actually it gives you that information in a jiffy, as you see on the lower side. All you do is just say auto ejection fraction. That gives you volumes and ejection fraction. How much time it takes? 15 seconds. That is artificial intelligence. But you want more information on function, you actually can again press a button called automatic functional imaging, and on the right side you would see that functional imaging. What is the functional imaging? So it gives you a lot more information here. Not only there is ejection fraction which is estimated, and the important thing is it is independent of operator. It's all automatic. So you do 100 times, you will still get the same ejection fraction. And is also giving you global longitudinal strain of 14%. You keep doing it, it will give you same information. This is an additional information on ejection fraction. So you can actually analyze this data further. The machine will do it. This is of course what you call as trying to find out are all segments contracting simultaneously, or there is a variation. This so-called dispersion. And of course with another push button or touch you will get that information, and you will find of course that the segments are not contracting homogeneously, although you are able to see visually that is contracting homogeneously. That figure of 82.8 millisecond is standard deviation of the segments achieving peak contraction. Normally it is less than 50 milliseconds, typically around 30 milliseconds. Here is 82 milliseconds. So segments are not contracting synchronously, although you can't see with the eye. That is the power of artificial imaging, artificial intelligence. You want to do further, of course. Now you have idea about the mechanical work of this individual. The mechanical, he has wasted work of 12%. You can't read that. Wasted work, normally wasted, myocardium has a work which gets wasted 5%. This is 12%. So this guy, although he is asymptomatic, came to me just for an echocardiogram yesterday for the heck of it. I mean, he's a doctor's nephew, I had to do it, but you find important information. The important information is that his global longitudinal strain is less, because it should be 20%. Anything 18 to 20% is normal, 16 to 80% borderline, less than 16% abnormal. He has an abnormal global longitudinal strain. So his left ventricular function abnormal. The segments are not contracting synchronously. So we got a lot of information. This is completely asymptomatic, but this particular algorithm which we have used in this system is called EchoNet dynamic algorithm. Why I'm telling you, this is an AI algorithm. So you can put a lot of AI algorithms in the system, and more are coming, which will make your job easy. It makes you efficient, reproducible, and faster. So all that information we have got in less than 1 minute. You can be sure this information available in 1 minute. Earlier, to get ejection fraction you would spend 10 minutes. Still you will have intraoperator variability, You don't do any longer, because the machine has been trained to do it, and machine will do it repeatedly, accurately, in a faster manner. This is artificial intelligence. Okay, we continue with the same individual. Now the next point is, I want to actually check things which were not checking earlier, like left atrial function in this 45 years asymptomatic gentleman, and I of course get a lot of information from his left atrium. That is accurate, consistent, faster. I get left atrial volume, how much it is emptying, what is the ejection fraction, and how much is the conduit function, contractile function, and of course the the holding capacity of the left atrium, all those values. Now, you don't have to go into that, but those figures on the right side tell you a story. The story is that left atrial reservoir strain is 23% or 24%, normal is 40%. So he has a non-compliant left atrium. His left atrial volume is normal, which is a relatively non-compliant left atrium. Now, think of what information we have got in this asymptomatic person. We know that his left atrial function is on the lower side. We know his left atrial function is not normal, all by AI. And the only thing we have to give is now another algorithm. If there was in the machine will tell what is the cause of his being having subclinical cardiac dysfunction, both atrium and ventricle. You have to put another algorithm and it gives you possibility. This is probably because of obesity, or it is because of coronary artery disease. That is the algorithm you need in artificial intelligence. Plus, after that, the next point, of course, would be what are his chances of developing heart failure in next 5 years? That is what the artificial intelligence should be able to predict. This is exactly what is happening now. So what we have got from this information, and all this is 2 minutes. In 2 minutes, we have got the complete information. We got multi-axial myocardial performance, muscle mechanics, cavity kinetics, all in 2 minutes, all because of artificial intelligence. That's what I'm saying, that artificial intelligence needed much more in echo than in any of the this. So what does the artificial intelligence provide you? It provides you structural recognition, image acquisition. It will tell you the image you are acquiring, whether it is appropriate or not. Automatic image analysis, I showed you. View recognition, it recognizes the views. You don't have to make an effort. Structural segmentation, we did that structural segmentation bullseye. Quantification, we showed you quantification. And automatic function imaging, as I showed you. So how does all this happen actually? All this happens because you have an image or you have a video, whatever is image. The image has, of course, a lot of features or vectors. These vectors actually get plotted in a matrix. And that feature matrix, there are thousands of frames and thousands of features. And these all get plotted. This is called a random forest. That random forest, this thing, finally actually goes through a diagnostic neural network, and that associated pixels with tissue and disease. These are the pixels which are behaving like this and this, and finally you get possibilities. So each algorithm has 3 components. There are machines which will tell you the vectors or the features of the vectors, artificial neural network, and of course the random forest where these are placed, and then the machine identifies that concentration of pixels in this area suggests this particular disease. So essentially, let us put it this way, and you can go further. The examples I showed you are not complete artificial intelligence. What are we looking at? You have the image data, and then you can put electronic medical records, the blood pressure, the heart rate, age, the body surface area, and what are the symptoms of this individual, what are the risk factors. That is called the large language module or large language mode, or I should go, in a case where you are only talking of left ventricle, left atrium, you can call it natural language processing. So this is a word or text. All data which you have given to the computer in the form of text is language processing. So if you tell that this ejection fraction is normal ejection, and this volumes are this, thickness is this, that is the language. That is the natural language of left ventricle function. You provide that kind of information through electronic medical records, and you will get a diagnosis of the disease. Now you'll need it. Not only it will give you possibility, but give you what probability is there of this being a disease. So you obviously know that the artificial intelligence has 2 components: machine learning, which is the basic step, and then deep learning, which requires multiple layers or deep convolutional networks. Put it the same way, machine learning is a simple thing. You tell the machine, this is a 4-chamber view. Machine says, okay, I have noted, it is a 4-chamber view. Then you go further and you say, okay, this is how you measure the ejection fraction. The machine learns it. So machine learning is basically, it does simple tasks, needs human interaction. You keep telling the machine, single layer, simple neural networks, less data and less computational power. But then you come to deep learning. Deep learning is much more complex. Complex tasking, multiple layers, big data, independent of human interaction. Now it behaves like a human being. It has a cognitive function like a human being. And it has complex neural networks and big computational power. So compute power has to be enormous to actually analyze this data. That is where we are moving towards. The compute power, as we go more and more, you'll see more and more AI network. So the machine learning basically is the first step really in artificial intelligence. There is a supervised learning where you tell the machine or computer, this is a four-chamber view, this is Paris and long axis view, this is normal ejection fraction, or this is how left ventricle should contract. And then there is an unsupervised learning where the machine will tell you, okay, I have identified a four-chamber view, and it will say what you have done is a four-chamber view. That is what is called unsupervised. And third part is reinforced. Then you tell, you are wrong. This is not a four-chamber view. This is something else. This is not three-chamber. And then the machine says, okay, I have learned it is a three-chamber view. This is called reinforced learning. So you understand how we actually do machine learning. Deep learning, on the other hand, is a different thing. Actually, it is much more complex. There are multiple neural networks. So you have a data input, you have hidden layers to process and weight the data, and then you have an output layer. The output layer will tell you, this is a patient who has hypertrophic obstructive cardiomyopathy. That is the kind of information we are trying to get. So put it the other way. You are putting the input, the images, then you have models. The important thing is actually artificial intelligence models. More you have models in a machine, more it will process it and more it will give you the information about the disease process, disease probability. So this ESC discussed various models. People came out with different models. Every group is trying to bring a model for a single disease or multiple disease. You want to see whether this patient has hypertensive heart disease or hypertrophic cardiomyopathy. Is it constriction or restriction? Right? You want to find out, is this individual whom I am seeing has genetic cardiomyopathy or it has a sarcoidosis? So that kind of things, actually, the models are being created. More and more models are being created. So an example is there. This is a fortune. So you don't give too many images to the model. You give one image to the model because you have to make it simple. If you do a 45 minutes of study, then you give all this to the, then you cannot actually make it faster. You give one, let us say we give one view to this. This is a four-chamber view. Through the deep learning, deep convolution neural network, you say, okay, tell me what is the possibility. So here is a 83 years old lady with suspected hypertrophic cardiomyopathy. What will you think of? It could be hypertrophic cardiomyopathy, it can be hypertensive heart disease, or it could be transthyretin amyloidosis. So the deep neural network will analyze these thousands of vectors, thousands of features, and tell you, well, this myocardium is more like amyloidosis and not like hypertrophic cardiomyopathy. You can go further, actually. You can also predict what is not there in that image, what is there in a CMR. Can I avoid a CMR? Yes, you can with artificial intelligence. It will tell you, okay, I have analyzed this four-chamber image and I find this patient is unlikely to have late gadolinium enhancements of myocardial fibrosis. Why is it important? Because in a patient of hypertrophic cardiomyopathy, you'll probably put an ICD in case there is fibrosis. So the machine can actually, based upon the features of the four-chamber view, based upon the texture, it is going to tell you this. So I'm trying to actually simplify, and I think I will stick to only the AI, nothing else. So the Echo was always portable, safe, cost-effective, radiation-free. Now it is efficient, mechanistic, scalable, modular, parametric, and predictive, all because of the AI. You are the newer models. So in this ESC, actually, somebody presented a model of predicting severity of aortic stenosis, all that data. You don't do anything. The machine tells you that this is the probability of this being severe aortic stenosis. This is the probability of this being which type of cardiomyopathy. I gave you an example, whether it's hypertrophic cardiomyopathy or amyloid cardiomyopathy. So these were some of the things which the interest was in this actually multimodal algorithm, pan echo. This is looking at all the data, actually giving you multiple possibilities in valvular heart disease, cardiomyopathies, and so on and so forth. So let me summarize it. The so the what is now becoming is that you are able to do multitasking. You are able to get actually much more quantitative data, much faster, much more reproducible, high accuracy. What else was presented? This was the other thing which was presented in ESC. This was the handheld echocardiogram sometimes 10 years back on the left side. Now you don't need anything. You just need a pen actually. The left side or the right side, you just have a pen. The you put the pen on the chest, which is a transducer, and on your mobile phone, all the images will come. That is what is called vScan Air. So now you have this small thing which is weighing just 50 gram in your pocket. You put it on the chest, and you have of course an app in your mobile phone. It gives you all the images, and of course it is AI enabled, so it will give you diagnosis also. That is what it is. So, but the more exciting was this, and this is my last slide. So we keep imaging actually the patient. We get picture, and then after we have collected pictures, we do offline analysis. Then we would, as I said, we make our own interpretation, write the report, and then give it to the there are actually AI models now available, which in the moment you acquire an image, it goes to the cloud and is already being analyzed, is already being reported. You have taken a long axis, it has already been reported within 15 seconds by artificial intelligence. Then whatever your views you are taking are being automatically reported. By the time you are finished with the study, not only the report is ready, report has been sent to the concerned person also. So for example, with this as I'm imaging, the machine is writing, left atrium is enlarged, left ventricle mildly enlarged, annuloplasty ring is seen, normal left ventricle function, so and so. So somewhere the report is being written automatically. You are not doing the reporting. That is wonderful, actually. You just scan it and the report is being written by the artificial intelligence. You have hardly any human interest. So a lot of exciting things are happening, and I think I will stop here. This could be a very, very long stuff, actually. Thank you very much.
Thank you, Professor J.C. Mohan, for your very exciting talk. As we all know that AI is coming in medicine in a very big way, and he has told how echocardiogram is going to revolutionize. Of course, this is coming in India also in a very big way. The other day, I was looking at the ECG also. Sometimes the ECGs reports are there that it can even predict sudden cardiac deaths. So I think it's coming in a big way in cardiology and the other fields of medicine and all. As you heard that it can make the procedure very quick, very simple. And only thing is we have to feed the data, proper data we have to feed in. A large amount of data has to be fed in, which has to be very reliable and it has to be very accurate, and we have to fill up all those things.
So
in our country,
other people are developing models.
Yeah,
These models have to be bought by the vendors,
yes,
and put in the machine. We don't have to do anything.
Yeah,
machine will do.
Our country has very limited data like this. You see, we cannot feed it because we don't have too much reliable data of echo or other things. Anyhow, any questions are there? Yeah, please. Yeah, be brief because we are already behind time. Yeah.
And based on that, the AI is going to interpret.
Yeah.
So for echocardiography, in particular, this database, incorporates data only from the echocardiographic, findings in, day-to-day work, or does it also have correlation with the better imaging techniques like CMR and other things?
So you can actually, the deep learning, you can give it information on echo, CMR, CT, then it will give you a composite diagnosis.
Yes, no. What I meant was, AI is giving you a better echo diagnosis than a human being, right? Now that is based only on what has been learned by the machine on echocardiographic findings, or it has also incorporated data from CMR findings.
Both ways. You can do both
Okay.
ways. So but the point is, if I need all the modalities, then there is no cost effectiveness. So as Dr. Manchanda said, I look at the ECG, and if I'm able to, this person has 35% ejection fraction, I avoid actually doing an echocardiogram. This is exactly the echo is doing. If I can tell this patient has myocardial fibrosis, I avoid doing a CMR. Or I'll probably do in highly selected cases and hence saving the cost and time.
Very exciting. Any other questions? If there are none, I think you're going to only discuss this. It's very exciting. Thank you very much. I think
So all as always been JC Mohan sir been talking about echocardiography and the AI has been coming up. Always been wonderful. So round of applause to JC Mohan sir. Thank you so much, sir, for a wonderful lecture what you have been provided on AI. The topic is vast, as Peeyush sir has also spoke about it. I think we require a lot of discussion on that particular topic, which takes huge amount of time. I think definitely we're going to go in depth on that in coming days. Surely now handing over again back to Meena ma'am. Over to you, ma'am, for the next speaker.
So, Dr. Peeyush Jain, it's my honor to welcome you to this meeting today. Dr. Peeyush Jain is Director Cardiology and Head Department of Preventive Cardiology at Fortis Escorts Heart Institute. He has been a guest faculty in several national and international conferences, both India and abroad. He was the former editor-in-chief, The Heart of the Matter. It's a bi-monthly journal of heart and diabetes care. So, author of 16 books on medicine and health in English and Hindi. Some books have also been translated in regional languages as well as in the Indonesian language. So, I think he's a member editorial board cardiology, member of the ethics committee and governing council, Lady Irwin College, Delhi University. So, very illustrious career, and it's my honor and privilege to invite you on the dais.
So only today I was discussing with my colleagues that I'm going here today to discuss 3 trials. If time permits, I will do all 3. Maybe if that does not happen, then maybe less than that. So why do you go for such meetings, and what is the purpose? So the purpose that is served for me is that I learn something. Because I always believe that if you are going somewhere, you have to read and you have to ask yourself questions and try to find out what you don't know already, and secondly, what is still don't is still not known even after the conclusion and the publication of these trials. So my first slide, and let me just try to give you some background to one of the trials which was presented in ESC 2025 regarding the efficacy and safety of dapagliflozin in acute heart failure. So the questions that I would like to ask here is, first question will be whether SGLT2 inhibitors, they help in acute heart failure when initiated during hospitalization. If yes, then how soon we can start it? Will it be worthwhile to start it on day 1 if the kidney functions are normal? And we know strong HF trial, it suggested very strongly that you have to initiate the guideline directed medical therapy in acute heart failure as soon as possible, because you need to reduce the risk of rehospitalization for further episodes of worsening of heart failure. So we don't have very firm answers to these questions. So this trial actually looked into this once again, and let me show you this data very rapidly. This was a randomized trial of 2,401 patients. Follow-up was 60 days, and the patients were all hospitalized for acute heart failure, and they were given dapagliflozin or placebo in equal number of patients, that is around 1,200 patients each. And the primary endpoint was time to cardiovascular death or worsening heart failure. And these were the key inclusion criteria, like the patient had symptoms and signs of fluid overload, elevated biomarker anti-pro-BNP or BNP, EGFR was more than 25. We can't give it with an EGFR of less than 20 or 30. And any LVEF, irrespective of what was the baseline LVEF, and with or without type 2 diabetes mellitus. And they were both de novo acute heart failure as well as worsening chronic heart failure. And the earliest they started dapagliflozin or placebo was more than 24 hours, but within 14 days after admission. So as early as possible, depending on the clinical feasibility of starting. And we all know what are these factors which determine our ability to start an SGLT2 inhibitor following acute decompensated heart failure. And then, of course, this is explained by the further no intensification of IV diuretics for more than 12 hours and no IV vasoactive agents for 24 hours. So before I comment on the overall impact of this trial, let me just first show you what were the findings in this. So looking at the cardiovascular death or worsening heart failure event, there was a trend towards a reduction, a difference of around slightly less than 2%, which was not statistically significant. Cardiovascular death or rehospitalization for heart failure. Once again, this was not statistically different, and all-cause mortality reduction by about a significant 34% over 60 days of follow-up. And this barely reached a significance as far as statistics are concerned, but may not be significant actually. So, uh, so this is a negative trial. That means that it is not always necessary to start dapagliflozin or maybe other SGLT2 inhibitors during hospitalization. And this is somewhat difficult to reconcile with our concept that we should actually initiate the treatment, the guideline-directed medical therapies for heart failure uh, as soon as possible, maybe in the hospital itself. So I just try to look into the other trials which looked into all these things. And the first trial that was published was in 2021, soloist worsening of heart failure trial. And this was basically a limited trial of sotagliflozin in type 2 diabetes mellitus patients. All the patients had diabetes mellitus, and they were recently admitted for worsening of heart failure. The small trial of 1,222 patients, and this was a positive trial. Uh, Sotagliflozin, which is not available out here to the best of my knowledge, reduce the risk of cardiovascular death, heart failure hospitalization, and urgent heart failure visits following discharge by about 33%, also improve the quality of life. And these benefits were seen as early as 15 days and maintained up to 90 days. So exactly when the SGLT2 inhibitors, or rather sotagliflozin, which was the glyphosine which was used in this trial, it was initiated either pre-discharge or within 3 days prior to discharge, not in the early phases of early days of admission for heart failure, acute heart failure. The other trial was the Impulse, published in European Heart Journal in 2022. And here the SGLT2 inhibitor that was used was empagliflozin. It was also a placebo-controlled trial. It was both for diabetics and non-diabetic patients who were admitted with acute worsening of heart failure. Once again, it was a small trial of 530 patients, and the follow-up here was 3 months. And the patients were relatively elderly here, 71 years of age. And once again, the empagliflozin was started after the patient had stabilized according to the standard recommendations. And here the there was some clinical benefit. Uh, if you look at the primary endpoint, which is usually a composite endpoint of death, number of heart failure events, time to first heart failure, and changes in the quality of life scores like KCCQ from day 0 to day 90, there was a clinical benefit overall with these composite endpoints, but one should remember that the risk of death there was a trend only. The risk of death was reduced by about just 1%, which was not statistically significant. The heart failure events, absolute reduction by about 4%, and that's it. And there was also a decrease in the risk of AKI during subsequent, follow-up. That is also there. So overall, significant clinical benefit with empagliflozin. So the conclusions are that the fact that dapagliflozin or empagliflozin, when initiated in patient with acute heart failure, when the patient is hospitalized, is beneficial, but we really don't know whether it will be beneficial when we start it during hospitalization. So this is something different from I'm so sorry. Different from our concept that we should actually initiate guideline directed medical therapy and initiate maybe glyphosines as the first choice, because they don't reduce blood pressure, they don't have electrolyte disturbances and all those things. So that is one thing. We don't know. And so overall, you could say that meta-analytic uh, calculations based on this impulse trial, which I already mentioned, soloist trial, and this DAPA Act HF, which was presented in ESC 2022, overall looks like that there is some reduction in CV death or worsening of heart failure events, and also maybe meta-analytically 43% reduction in all-cause mortality. But the individual trials actually are less impressive. So far, it is mostly based on the meta-analysis. The other thing that I would like to discuss here, which is not shown in any of these slides, is what about initiating dapagliflozin on day 1 of admission for acute heart failure? We have got very, very limited related to that, and we are still in the process of knowing whether it is safe, whether it does reduce the severity of heart failure, and we are still using only surrogate endpoints like the requirement for the loop diuretics. Uh, Ultimately during hospitalization. So there was a trial which was published in 2024 in JAC, which looked into the uh, safety and efficacy of early dapagliflozin in acute heart failure. 240 patients only, and initiation within 24 hours of admission. And this was compared with the standard of care, which means that we start with loop diuretics, and then when the patient is decongested, patient does not have AKI, creatinine is not rising, and the patient is not hypovolemic, and patient is not hypotensive, then we start with other agents. So here the primary endpoint was not a clinical endpoint. It was just the diuretics, like how much diuretics we will require. So it was found that there was no difference between DAPA and usual care. So if you initiate the dapagliflozin or maybe EMPA also, I don't know because that has not been tried. This diuretic efficiency actually does not change, but some reduction in the requirement for diuretic. So a little positive signal and no safety issues, but we still don't know that we should, or rather we can start a glyphosine along with loop diuretics on day 1 of worsening of heart failure requiring hospitalization due to acute heart failure. So that is all I would like to say about this trial. Let me go further. So regarding beta blockers, and that is also a very important issue. Initiation of beta blockers following a myocardial infarction. So the question that I may like to ask from myself is, will all the patients who had myocardial infarction or who have myocardial infarction recently require a beta blocker therapy? That is number one. Second question might be which beta blocker? Thirdly, how long and what are the benefits? So the answers to these questions are actually very tricky and controversial. Most of us think that we should all give a beta blocker following acute myocardial infarction, and this is based on a very old trial called BART trial, which was initiated in 1977 and published in 1981. And if you remember, at that time, echocardiography was not uh, very well developed. So we really don't know how many of these patients exactly had heart, LV dysfunction as defined LVEF of less than 40%. So we don't know, but the literature suggests that probably majority of these patients were having some LV dysfunction, but I'm not so sure about it because this is something that remains unpublished. So in this particular trial, propranolol was used following myocardial infarction, and it was a relatively quite a large trial for that time, 3,800 patients, and the total mortality actually was reduced by about 1.6% in this, which was significant. CHD mortality was also reduced 6.2% in with propranolol as compared to placebo, which was 8.5%. And importantly, there was also about 1.3% reduction in the sudden cardiac death. So this was the basis of post-MI beta blockers. But then what was the duration of therapy that was recommended? For a very, very long time, it was recommended for at least 3 years, but most clinicians like me and others, who are sitting here, they have been using post-MI beta blockers for more or less indefinitely. And this is actually not mm, confirmed as the sound strategic, approach because we don't have data on that. And one should also remember that that was the time when revascularization was not common. So the other question that I may like to ask from myself is, what about those patients with the acute myocardial infarction who undergo primary PCI or a successful thrombolysis? And lastly, I may also like to ask, what is the evidence that a patient who had myocardial infarction but has preserved ejection fraction, should I use a beta blocker for these patients? For how long? What benefits will be there? So very limited data on that, but there is some data. The other article and other study that also indicated that beta blockers are helpful in patients with post-MI LV dysfunction was the Capricorn trial, which actually used carvedilol, not propranolol here. And these were all patients who had post, MI status with low ejection fraction. And importantly, these patients were already on ACE therapy. So this was also a relatively large trial for that time, 2,000 patients. And it reduced the overall mortality by about 23% in these cases. No, 23% is the relative risk reduction, of course, 12% versus 15%. So 3% absolute risk reduction, which means if you treat about 33 to 35 patients, you will actually save one life. But it did not reduce the combined endpoint of all-cause mortality or CV hospitalization. The other important thing here was that it also reduced the risk of serious rhythm disorders like atrial flutter fibrillation, ventricular tachycardia, and ventricular fibrillation. So this was also a positive trial. But once again, that was a time when revascularization by PCI was not very, very common. So here we have some tricky questions to answer, which I don't have enough evidence there. But what about people who have got a normal ejection fraction? What about patients who had a PCI? Or what about patients who had got mildly reduced ejection fraction post MI? Will they be benefited with the beta blocker therapy? So we have got two trials, and I have, slides to show only for one trial, that is Betami Dan block trial, which was done in Norway and Denmark. So 5,574 patients, they were randomized to a beta blocker, mostly metoprolol. Median age was 63, and about 80% of the patients were males. And 16% of these patients had got LVEF of 40% to 49%. And more than 90% of them underwent stenting. So these were the primary endpoints here: all-cause mortality or MACE, major adverse cardiovascular events, and that included recurrent MI, unplanned coronary revascularization, heart failure, ischemic stroke, and malignant ventricular arrhythmias. So there was a median follow-up of 3.5 years. And the primary endpoint was death or MACE, including myocardial infarction, as I said, unplanned revascularization, ischemic stroke, heart failure, or malignant ventricular arrhythmias. So the findings were that with the institution of beta blocker, mostly metoprolol, there was some reduction in the risk, 14.2% in patients who were given beta blocker, and 16.3% in those who are on no beta blocker. So 2.1% absolute risk reduction and a 15% relative risk reduction. So there was a benefit there. But the question that I might like to ask here is, what happened to those patients who had, mildly reduced ejection fraction, or they had, normal ejection fraction? So unfortunately, I don't have data on that, because this was presented very, very, very recently. So I may like to know what happened in those patients who had at least mildly reduced ejection fraction, because previously we don't have any evidence that post MI patient with mildly reduced ejection fraction will benefit from beta blockers. So we have got only a meta-analysis, and this meta-analysis and that included very small trials. Total number was 1,885 patients, and they had mildly reduced EF following MI, and the primary outcome seemed to improve in post-MI patient with institution of beta blocker therapy. 32.6 per thousand patient years of use versus 43 per thousand patient years. So relative risk reduction 25%. But when you're talking of thousands of patient years, actual reduction is very, very small. And mind you, this is based on very small trials, including one randomized capital RCT, which was also a small trial. So this is something which needs to be taken with a pinch of salt, and we need more studies in patients with mildly reduced ejection fraction, and and who mostly out of these should be having a post PCI status or post CBG status, something like that, because we really need to know whether beta blockers have to be given to all patients with MI following MI, or it has got to be given only to a limited number of patients with maybe reduced ejection fraction or not. So I must also say that there was another trial, trial, which was also published along the same lines and published. It was not published really; it was published as a press release. I could just get hold of the press release at the moment. This was also presented in ESC 2025. More than 3,500 patients. And bisoprolol was the beta blocker. It was compared with a placebo, not a placebo, but no beta blocker, just the standard of care. And here the mean EF was 57%, but 12% patient had LVEF of 40% to 49%. And once again, more than 90% had coronary stenting. So after 3.7 years of follow-up, and data is not shown out here, the primary endpoint was not different between the two. 22.5% per 1,000 patient years versus 21.7% per 1,000 patient years. So no signal of benefit for those with myocardial infarction recently. So this is a negative trial. So what does it all mean? And let me just try to answer these questions based on what we know now from BHART trial, from Capricorn trial with Bitami Dan block trial, and the capital RCT and other smaller trials, and then of course Redo trial now. We don't know the final answer, but possibly all patients who had recent myocardial infarction don't require a beta blocker. That is one. Secondly, which beta blocker, that also we don't know. But metoprolol has been used most often so far. Bisoprolol is getting more popular, and we can discuss the reasons. For how long, we really don't know. And fourthly, what are the benefits? There are signals of benefit in different trials. Now these signals, some of these are strong, some of these are not so strong, and I've already discussed that. So this is what it is, and can I go to the next, or should I stop here?
Stop it here. We can have discussion.
Yeah.
Because
I
these
think
are
because
two very
it takes a lot
interesting.
of time. I don't want to do that.
Thank you very much, Peeyush. I think you discussed two studies which are of great clinical importance and all. Because dapagliflozin, the SGLT2 inhibitors are the cornerstone, one of the strongest pillars of heart failure treatment. Actually, they are given both for reduced ejection fraction and preserved ejection fraction. The only drug which has been approved in preserved ejection fraction. Extremely good drugs. But as you said that they should not be given in patients who have acute heart failure. I think there are limitations of these studies. Our practical experience shows that we use them as one of the earliest because they have no hemodynamic effects, etc. The studies which you showed have very short follow.
Yes.
And the curves were just widening when they stopped it. I think if they had gone, I think clinically, I don't think we will change. Will you? Doctor is an authority here sitting in heart failure. So personally, I will not like to stop this or not give an acute heart failure. As long as the patient becomes stable, one can give it, and it's a very useful drug, very little side effects and all that. The second trial which you showed is also very controversial because I have been into cardiology for the last 60 years. All the trials before reperfusion came were positive for beta blockers. Beta blockers were given for both left ventricular dysfunction or not. Actually, the BUT trial which you reviewed, clinically they had ruled out left heart failure because I did the first study and I was pulled up in CSI. How can you give beta blockers in heart failure? Absolute contraindication was there. And but we did show that there was some benefit in 40-45% ejection fraction. So I think before all those trials were, there was a meta-analysis done by, I think, Dr. Bangalore, that patients who do not get reperfusion, this was either thrombolytic or stents, benefit. And those who have revascularization and left ventricle function is normal, they don't benefit. But as I said, the result is still not out, but this is what most of the guidelines say, that beta blockers have a very limited role after myocardial infarction if the left ventricle function is normal. If it is having LV dysfunction, you have to get that. So that's my take. Any questions or comments from Dr. Chopra is an authority in heart failure. Yes, Jesse.
I think I would restrict my comments to beta blockers and myocardial infarction. Dr. Peeyush rightly mentioned that there were positive trials 40 years back, beta blocker heart rate trial, Norwegian Timolol trial. These were two positive trials. But even in that era, and the Comet trial, which was a Chinese trial of 52,000 patients, thrombolized and then given beta blockers and showed some 7% reduction in mortality. However, there was, even in that era, 40 years back, there was a negative trial called Miami study, metoprolol and acute myocardial infarction. So even at that time, there was some doubt in our mind whether everybody will benefit from beta blockers or not. Then we rewind to Siripal Bangalore's meta-analysis 2012 published in JACC. He said only people who are non-reperfused benefit, and those who are reperfused do not benefit from beta blockers. That status continued. 2023, the ESC guideline said ejection fraction less than 40% class 1A, all other myocardial infarction class 2AB, which means you can give.
Yes, you can.
But the Americans did not change this. The July 2025, that is just 1.5 months back, ACCHA came out with guidelines for STEMI. It is the first author is Sunil Rao from Duke. And the guidelines said beta blockers are class 1A indications post-MI in all the patients, regardless of ejection fraction. Now that was a surprising thing. So and this was despite the fact that a year earlier, reduced AMI study had been published in New England Journal of Medicine, which was presented in March 2024 in ACC. 5,200 patients, 3.5 years follow-up, beta blocker having absolutely no effect on any of the parameters.
In this
Re-MI,
EF was more than 50%.
Yeah, but the EF was more than 50%.
So no benefit there.
Yeah, no benefit.
Yeah.
Reboot trial also equally big study, 8,000 patients, but these are ejection fraction above 40%. This is Spanish and Italian trial with Ibanez presented actually, and I was there. It was negative trials. The Betami and of course Dan Block trials, 2 different countries, they pulled together 15% reduction with a p-value of 0.03. The chances of you reproducing this are just 60%. 40% chance you will be wrong. Remember the p-value. P-value is 0.03 only. That is not a very strong study. So my point actually is we still are confused with beta blockers.
That is what I was saying.
Should I continue to use beta blockers? I would continue to use. The reason is very simple. Most of our myocardial infarction patients either don't get reperfusion right in time or get delayed, which they will continue to have significant LV dysfunction in that 40 to 49% range. And so I would give beta blockers.
So we will not be wrong actually.
Yes.
Because
Chopra will like to
LV dysfunction.
So I think post-MI is a mixed bag. If somebody has LV dysfunction, less than 45% or some 40%, then of course, beta blockers will come in. There are 2 situations. If somebody has an ejection fraction, for example, 55%, there's no reversible ischemia, there's no angina. That is the group where you have to see whether it's really going to be helpful or not. And there, if you demonstrate that there's no reversible ischemia, there's no angina, LV functions are normal, then of course, there is data to say that they may not be needed. Again, there's a controversy.
So biological feasibility is also not there. Beta blocker will not benefit.
Because in beta blockers as well other guideline directed medical therapy, as the ejection fraction comes down, the neurohormonal benefits keep on increasing. The benefits of neurohormonal modifying agents keep on increasing, whether these are ACE inhibitors or beta blockers and so on and so forth. As far as dapagliflozin or SGLT2 inhibitors are concerned, I think there is data now to say that in heart failure, they can be started relatively early. Acute myocardial infarction trials have generally not been as strongly positive as have been reduced ejection fraction trials. Also, as Dr. Manchanda rightly mentioned, for financial reasons, trials are getting shorter and shorter. So you see that, curves are diverging and suddenly at 90 days, they are cut off. What would happen had they been followed like the previous trials for 2 years or 3 years? We don't have that information.
Yeah, but this DAPA Act HF suffers from 3 infirmities. Number 1, we have data from Trivandrum Heart Failure Registry that 30 days rehospitalization is 30%.
That's heart failure.
No, I'm talking acute. Trivandrum Heart Failure, acute heart failure registry. At 30 days post-discharge, rehospitalized for heart failure, 30%. This study had 13%. So it is grossly underpowered.
The point is that
Trivandrum heart study had only
60 days.
It had only 2, pillars. It did not have all the 4 pillars.
No, just I think you're still not even understanding. The events which are occurring in DAPA Act HF at 60 days are much lower than what happens in real world. That is the first thing. Number 2, the duration of follow-up 60 days too short. Impulse had 90 days. Solus WHO had 9 months. You have DAPA Act HF, although curves are diverging, 60 days. But major issue is that somehow they selected a group of individuals who were low risk to begin with. And that is why, although 14% reduction, it did not achieve statistical significance. The all registry says 30 days rehospitalization are 30%. How come there are only 14% here?
I'll tell you why. There's a sub-analysis of Trivandrum Heart Failure Registry. There are two groups. One is where guideline-directed medical therapy was given, and one is a total cohort. If you take the group in which all three drugs at that time, there were no SGLT2 inhibitors, the events are much, much lower. And if you take the totality, then they are much more. And then there is another analysis, those who were given GDMT and those who did not receive full GDMT, and there's a huge difference, which is to be expected.
So because of the short study, it was actually not statistically powered to look into these things very correctly.
Any questions anybody would like to ask or any comments? I hope you are not confused and all things. I think more he
Clearly stated a 43% reduction in mortality. I think the bulk of data suggests first we will able to take pictures in acute heart failure as well as in chronic heart failure, regardless of ejection.
But not on day one.
No,
No, no.
after 24 hours.
Yes, after 24 hours,
Oh.
once you, yes.
once the patient gets stabilized,
Yes, yes.
all other trials have also shown other drugs, patients get stabilized.
Yeah.
For 24 hours, the diuretics are not increased. That's the definition. So once a person gets stabilized, then he can start.
To ask me what the new guidelines say, the new guidelines say A. They're not going to give a class 1A. Based upon this meta-analysis.
Just one
Yeah.
quick comment about the beta blockers post-MI in the era of revascularization. So once you revascularize a patient, there is an improvement in LVEF also. So the patient's risk actually changes, and beta blocker may not be necessary.
But if you see 40% of those patients have still ischemia, residual ischemia, that is also a point. You see, if they have ischemia, beta blockers are very helpful. If you do a treadmill test after angioplasty or after,
I don't think so. We know from Clarify registry, which we were part of, and Reach registry, that beta blockers don't reduce myocardial stable angina. They don't reduce death. All they do is reduce the frequency of angina. So after a year, after 6 months of ACS, patients mostly behave like chronic coronary syndrome.
Yeah.
So remember, beta blocker probably would be downgraded to 2A status based on all that thing. But if you ask me in India, will I be continue to use beta blocker post AMI? I would continue to use. And when I do echo, I mostly find ejection fraction below 50%. Below, mostly is below 50%.
even if ejection fraction is normal, they have some amount of ischemia is always there. Even with normal coronaries, they could have small vessel disease.
Yeah, but
and there you give
know,
beta blocker.
the trials don't talk of ischemia, and we are only extrapolating.
But ischemia, there is no question beta blockers are the drug of choice. Chronic stable angina, for example.
yeah, they are the drug of choice by convention.
Yeah.
Without any evidence. So this is also an interesting story. Chronic coronary syndrome, beta blockers are first line on drug with zero evidence.
No, the reason
Just
is
symptomatic
they
relief.
improve- No, quality of
Symptomatic
life. They
relief
improve.
So
No,
you will have same kind of angina relief with the long-acting nitrates and calcium channel.
Yeah, so only symptomatic relief. So no
So
special
equal amount.
no
Equal
special
amount.
benefit.
no, but single drug is not really effective. It's
No,
two drugs.
so, yeah, but
None of them reduces mortality. Unfortunately, none of the anti-anginas reduce mortality. They improve the quality of life. Because the mortality in chronic stable angina is 2%.
yeah.
How much
So,
can you reduce?
so,
this is a stable condition.
As Robert Ferrari said, you can use any of the 6 anti-angina drugs in chronic stable angina to begin with.
Yeah.
You will have similar results.
Yeah.
Yeah, whatever works.
But if it doesn't help, then you have to combine 2 or 3.
Absolutely.
That's also
You keep combining. Actually, once you reach 3, then
Yeah.
think revascularization.
Okay. Thank you very much.
Thank
I
you,
think
sir.
it was an excellent talk. And
Oh, so wow, great. I think discussion has been happened on the beta blocker. That's the reason we kept that particular topic because it's been more discussed on the ESC platform of beta blocker after MI discontinuation. Thank you so much, sir. Wonderful session has been happened. I'm requesting Meena ma'am to hand over. Clap those. Over to you, ma'am. We are going to the last session right now. I'm just requesting Meena ma'am to introduce our next speaker for the last session.
Sir doesn't seem to be well. Dr. VK Chopra, you're coughing. So thank you for still making it here because we all wanted to listen to you. So it's my honor to introduce Dr. V.K. Chopra. He's the Senior Director, Clinical Cardiology, Heart Failure and Research. He works at the Max Super Speciality Hospital, Saket, New Delhi. He's the founding president and member board of governors, Heart Failure Association of India. And he's a fellow of the Cardiology Society of India, fellow of the European Society of Cardiology, and also fellow of the Heart Failure Association of the ESC. So, a very warm welcome, sir, and your talk now.
Thank you, Meena. This will probably be the talk which is much more boring than the previous two exciting talks. But anyway, here it is. So, basically, guidelines are written by different organizations for various diseases, and they generally give us guidance. They're only guidelines. They give us guidance about how to manage our patients. It says in every guidelines that ultimately the decision rests with the clinician. These are broad guidelines. Be that as it may, as new evidence accumulates, and we know the number of trials which are accumulating at a frantic pace, then every few years there's an update on the guidelines. So I'm going to give update on two guidelines. The changes may be sometimes very, very minimal. One is on valvular heart disease, on which Dr. Mohan is an authority, and second is dyslipidemias, where Dr. Peeyush Jain has left probably, but Mohan is there. So this is management of coronary artery disease in patients with valvular heart disease. What happens when there is coronary artery disease and how to diagnose it? In 23, it was mentioned that CT angio should be considered as an alternative to coronary angiography before valve surgery in patients with severe valvular heart disease and low probability. But now CT angiography has been upgraded. It is recommended before valve intervention in patients where probability of coronary artery disease is either low or intermediate. So coronary CT angiography should be considered. And in our kind of a community where coronary artery disease occurs at a relatively younger age as compared to the Western population, one has to see which are the patients where there is some possibility. Probably the probability will be there at a relatively younger age. Then we come to management of aortic regurgitation. In 21, it was mentioned that surgery may be considered in asymptomatic patients with left ventricular end systolic diameter index of 20. And in 25, this has been revised to 22, which means that you can probably wait for a little longer time. And this is, but LV and systolic volume of more than 45, especially in patients where there's a low body size, or resting ejection fraction less than 55% if surgical risk is low. So this is the other indication, other revision. Then mode of intervention and severe aortic regurgitation. In 21, it was that aortic valve repair. I don't know how many people do aortic valve repair in our country, but there are centers which do it. Recently, we had a patient who had it done in Johns Hopkins. The new guidelines recommend that aortic valve repair should be considered in selected patients with severe aortic regurgitation in experienced centers. TAVI may be considered for treatment of severe aortic regurgitation in symptomatic patients ineligible for surgery after a discussion with the heart team if anatomy is suitable. We know that mostly it is done for aortic stenosis, but if surgery is not possible, then in experienced centers, this is something which can be considered. What about asymptomatic aortic stenosis? The new guidelines mention that intervention should be considered in asymptomatic patients, which is confirmed with a normal exercise test, if feasible, with severe high-grade aortic stenosis and ejection fraction over 50% as an alternative to active surveillance. So even if a person is asymptomatic, but there is severe high-grade aortic stenosis, LV ejection fraction is normal, and the procedure risk is low in an experienced center, it should be considered. What about the mode of intervention? In 25 recommendations, it says that TAVI is recommended in patients more than 70 years with tricuspid aortic valve stenosis, which is the usual anatomy of the valve, if anatomy is suitable, but less than 70 years, if the surgical risk is low, surgical replacement is still recommended. SAVR or TAVI, that is surgical or transcatheter aortic valve interventions, are recommended for other patients for aortic bioprosthetic heart valve. That means in other patients, bioprosthetic heart valve should be considered according to heart team assessment. non-transfer, there are some patients where femoral approach is not possible, then non-femoral approach should be considered. Many times you go through the carotid artery and replace the valve. A new guideline indication is that TAVI may be considered for treatment of severe bicuspid aortic valve in patients with increased surgical risk if anatomy is suitable. Till very recently, bicuspid aortic valve was considered not such a strong indication for TAVI, but now it is being done. What about primary mitral regurgitation? That means actual heart valve when the mitral valve is diseased as such, as compared to the conditions where it is secondary to left ventricular or left atrial dysfunction. So primary mitral regurgitation, the new guidelines consider about transcatheter edge-to-edge repair. It should be considered in symptomatic patients with severe primary mitral valve regurgitation who are anatomically suitable and at high surgical risk according to heart team. Now, this may not be very suitable for our country because a lot of primary mitral regurgitation is due to rheumatic heart disease, but if it is due to floppy valve or mitral valve prolapse, then it is something which can be considered. Minimal invasive mitral valve surgery may be considered at experienced centers to reduce the length of stay and accelerate recovery. So either preferable will be transcatheter edge-to-edge repair or minimally invasive surgery with a small incision. In severe secondary mitral regurgitation without coronary artery disease, that is patients where it is due to left ventricular dysfunction or left atrial dysfunction. So transcatheter edge-to-edge repair is recommended to reduce heart failure hospitalization and improve quality of life if a person is hemodynamically stable and they are symptomatic with ejection fraction less than 50% and severe persistent mitral regurgitation despite GDMT. We know that once there's left ventricular dilatation, many times after GDMT, good GDMT is instituted, the LV volumes come down and mitral regurgitation may become less. But if it still persists and it is severe and symptomatic, then one should consider transcatheter repair. Of course, depends upon clinical and echo criteria. Then there is a condition called atrial secondary mitral regurgitation, where it is mitral regurgitation is mainly due to atrial fibrillation and such like, where it is not really ventricular dilatation as much as the atrial pathology. So mitral valve surgery, surgical AF ablation. I was a little bit surprised about this. I don't know how many people do surgical AF ablation today, but that is what it says. Mitral valve surgery, surgical atrial fibrillation, if indicated, and appendage closure should be considered in symptomatic patients with severe atrial mitral regurgitation under optimal medical therapy. And here also the transcatheter repair may be considered in symptomatic patients with severe atrial mitral regurgitation, not second suitable for surgery after optimization of medical therapy. So these are the indications which are coming in. Also, we have to recognize a condition of atrial mitral regurgitation also. What about tricuspid regurgitation? In 25 years, recommendations are patients with tricuspid regurgitation and left-sided valvular heart disease. So if tricuspid regurgitation is secondary to mitral valve disease and right side heart failure and tricuspid regurgitation is a result of that, then if you are taking care of mitral valve disease, concomitant tricuspid valve repair should be considered in patients with moderate or secondary TR to avoid progression of tricuspid regurgitation and right ventricular remodeling. Concomitant tricuspid valve repair may be considered in selective patients with mild secondary TR and tricuspid annular dilatation. So if either tricuspid regurgitation is moderate or severe, or even if it is mild but there is a significant mitral annular dilatation, it should be considered. What about primary tricuspid regurgitation, where it is not due to left heart disease? Transcatheter valve treatments are available today, and they should be considered to improve the quality of life in patients where there is severe tricuspid regurgitation leading on to heart failure and other adverse events despite medical therapy. So there are devices available to tackle the tricuspid valve regurgitation. Indication for intervention in mixed aortic stenosis and moderate. So aortic stenosis plus aortic regurgitation. So the new guideline says that intervention is recommended if patients are symptomatic with mixed moderate aortic stenosis and regurg and a mean gradient of 40 with Vmax more than 8. That is the intervention is recommended also in asymptomatic patients with mixed aortic valve disease with Vmax over 40 and ejection fraction less than 50. So if either the Vmax is more and the gradient is more than 40, or Vmax more than 4, and ejection fraction has started dropping. So drop in ejection fraction in aortic valve disease is a red herring, and that should be taken care of before it drops still further. In severe mitral stenosis, of course, we know that transcatheter mitral valve implantation may be considered in symptomatic patients. So this is again something new. When there was heavy annular calcification, surgical repair is not possible, and even the balloon mitral valvotomy may not work because of heavy calcification. But nowadays there are techniques available where transcatheter mitral valve replacement can be done. So that is what is recommended now. So this is again something new. The prosthetic valves, including anticoagulation, the selection of prosthetic valve, mechanical heart valve should be considered in relatively younger patients, and bioprosthetic heart valve in relatively elderly people. Management of antithrombotic therapy and management with prosthetic heart valve, we know that it is recommended that INR targets are based upon the type and position of metallic heart valve. They basically have to be given lifelong. Management of antithrombotic therapy in patients with mechanical heart valves undergoing elective non-cardiac surgery. If the surgical bleeding risk is low or minimal, then you can continue with vitamin K antagonists. Again, that is something which is most of the time for any surgery, vitamin K antagonists are stopped. But here the guidelines say that if there is only minor or minimally invasive intervention, then one can continue. Transcatheter aortic valve implantation without indication for oral anticoagulation, DAPT is not recommended to prevent thrombosis for TAVI. So after transcatheter aortic valve replacement, you do not need dual antiplatelet therapy. And now a few lines about the focused update on guidelines for dyslipidemias. So 25 recommendations. So one is SCORE. This is one of the scores which is done to calculate the risk of patients developing atherosclerotic coronary artery disease, and takes into consideration the previous presence of cardiovascular atherosclerotic disease, diabetes, chronic kidney disease, or severe dyslipidemia, to estimate what is the 10-year risk of fatal or non-fatal MI. And then there is score to OP, that is for older persons. And there, with if the age is over 70, then there is a modification. If there is a presence of subclinical coronary artery disease, that means not clinically manifest, but high calcium score, or on CT angio you find, then that modifies the risk upwards. Risk modifiers therefore should be considered in individuals who are at moderate risk, or individuals around treatment decision threshold, to improve the risk classification. So in 25, the new recommendations are presence of subclinical atherosclerosis by imaging or increased calcium score on CT should be considered as a risk modifier, placing them at a relatively higher risk. So from moderate risk, they may become a high risk, and that should be taken into consideration for treatment decisions. The cardiovascular risk assessment. Now, this is something which most of us know already. In primary prevention, the pharmacological LDL lowering agents are recommended at if LDL is 70 or more, so it has to come down. In high risk, it should be brought down below 100, and this is despite optimization of non-pharmacological methods. So in these people, statins or something similar has to be given, and in very high risk, less than 70 is the target, and in high risk, less than 100 is the target. The guidelines in India are slightly different because of propensity to have coronary artery disease at a much younger age, and also a much higher incidence of coronary artery disease. So in our country, probably the Indian guidelines mention at least 10 to 20 milligrams at a lower target, but maybe Dr. Peeyush Jain will comment on that. In very high risk people, LDL lowering therapy should be considered in persons where it is, so less than 70 it has to be done, but in very high risk people, even below 70, if it is more than 55, it should be considered. So that I think takes into consideration populations like our country. And same thing goes for high risk and moderate risk also, that even at a slightly lower recommended level than what is recommended in certain populations, the treatment can be started. What about pharmacological low density lipoprotein lowering? Now, non-statin therapies with proven cardiovascular benefit taken alone or in combination are recommended for patients who are unable to take statin therapy. So takes into consideration statin intolerant, and there the role of bempedoic acid with or without ezetimibe comes into consideration. Of course, now we have PCSK9 inhibitors and inclisiran also, which should be considered in these patients. People who have homozygous familial dyslipidemia, they are notoriously resistant to these drugs, and there probably these newer agents like PCSK9 inhibitors or inclisiran should be considered strong. Yeah. Hmm. Yeah. Actually, I was also very confused about this. I went to the main guideline. So if you go, it is recommended, and here it is says should be considered. So what it means is that that's the right touch. It was very confusing. I asked 3 or 4 people, nobody could clarify. Then I read the main guidelines, they say the practice. The idea is it doesn't decide that in the trial, in the main document, it's not. I don't think it's correct. Actually, it's has to be secondary. So it is not also the man saying it is considered. No, it is to be considered, not that is recommended. But we will consider it in certain populations, like ours. And in the text also, it is described in the same way. It is not just a misprint. If it was a misprint in the table, I would have understood. If you start looking at things bigger, you will never be. They are very confusing. Not necessarily. Not as much variability in a high risk or very high.
Very high risk, less than 55.
Yeah. So definitely it should be less than 70, but consider if you want to bring it down to 30.
Yeah, in some patients you will.
I read this maybe 10 times and I've read the full chapter also 2-3 times.
You connected at least 3 times over medical team.
I connected with the medical team. I talked to 3-4 people also. Yes.
No, but it is clear that it is recommended to get it below 55,
Yes.
but if somebody is between 55 and 70, you can consider still getting the LDL lowered. That is what it is trying to say. Yeah.
Yeah, sure. The patient's LDL is slightly more.
Yeah.
But he's at very high risk. What does that mean to me? It means that this very high risk is not
Already has it.
not because of cholesterol, it is because of something else.
Yeah.
So what I will do is I will treat those factors rather than cholesterol. No, not necessarily. Very high risk means established atherosclerotic.
No, then becomes secondary prevention. No, sir, then it becomes secondary prevention.
It's diabetes.
Yeah.
Really not.
Then it
And
becomes
secondly, familiar hypercholesterolemia.
Familiar hypercholesterolemia, diabetes, chronic kidney
Even
disease.
kidney disease for that matter. You see, if they have high risk, many of the risk factors, except of course, atherosclerotic disease.
Yeah, but this also includes moderate CKD and severe CKD falls in very high risk,
Yeah.
and moderate CKD falls in high risk.
Yeah.
That is also primary prevention to
Yeah,
begin with, actually.
that's right. So CKD is primary, diabetes is also.
Okay.
Diabetes is primary.
So then next we come to those patients who present with acute coronary syndrome. The upper line says that if they are already on a statin or a lipid lowering therapy and they get acute coronary syndrome, that has to be uptitrated. And if they are not on that, then it should be initiated. And it should be high intensity statin with or without with ezetimibe, because you have to bring it down quickly. After that is recommendation for hypertriglyceridemia. That has always been something which there has been a lot of discussion, and there are opinions both way or the other. So the new guidelines say that icosa pentethyl, which I don't know how many of us use. At least I have never used it, but I'm sure people are using it. It should be considered in combination with a statin in high risk or very high risk patients with elevated triglycerides, which is between 135 to 499. Over 500 anyway, it has to be lowered because there's a high risk of pancreatitis. And it also says in the text that fibrates, they are not really recommended as first-line drugs. They should still be statins. But drugs like saroglitazole and fenofibrate, they are extensively used in our country. So that is something which is not recommended in the guidelines at least.
Icosapentaenoid ethyl and not icosapentaenoic acid. Now that is important. Neither decahexanoic acid nor icosapentaenoic acid has to be ethyl. That is what it says. Because they reduce it is with ethyl, not with anything else.
Okay, then if somebody has human immunodeficiency virus syndrome, they need to be on on lipid-lowering therapies, and same is true for those who are receiving cancer therapy. It should statins should be considered in adult patients with high or very high risk of developing chemotherapy-related cardiovascular toxicity to reduce the risk of anthracycline-induced cardiac dysfunction. Dietary supplements or vitamins without documented safety and significant LDL lowering are not recommended to lower the risk of atherosclerotic coronary artery disease. Thank you.
Thank you, Dr. Chopra, for your very brief and very clear-cut outlines regarding these two very important conditions.
First of all, thank you so much for coming from long time, sir, and accepting the request from Lloyd Healthcare and talking about guideline. Guideline has always has a lot of debate, a lot of discussions in and out. I think you have been very well. So thank you so much. Over to you.
Yeah, I'd just like to have a couple of comments. You see, these guidelines for these valvular diseases are really not Indian ones. You don't need angiography in all patients of valvular regurgitation. We have patients who are 20 years, 30 years and all that. It's about 40 years. Actually, at one time, we had suggested it's only above the age of 50 or 45 in females you should do it. But I think above 40, as he said, possibly is right. So it's in small children, it's not necessary to do that. And secondly, as he said, the guidelines have become very, very clear now. When to treat asymptomatic aortic regurgitation, not much change. And aortic stenosis especially, it's very important. And I think they talk of these mitral clips, which are not very frequently being done. I think here we would rather do the surgery, which is simpler and all. There are some people who are doing this mitral valve repairs also in non-rheumatic. In rheumatic, you can't do repairs. And therefore, I think it's very important. Thank you very much. I think these guidelines are very important. And I'm sure all of you see these patients. There are no guidelines mentioned for mitral stenosis, which is the commonest problem we have. And we know the indications for that you can do the valvotomy in those patients who are having significant mitral stenosis. I think we all have that. And you can do it even in calcified valve. You can do it even in certain left atrial clots and so on and so forth. I think we should be really very careful about mitral stenosis, which is very common. It's not given, I think, the guideline, as far as I know, because these are not really talking of the young people. They're talking of the elderly. They teach young people in the pediatric guidelines or something like that. And finally, I think dyslipidemia is a very, very important condition. And as he said, the guidelines very clearly show that you should try to lower the LDL as fast as possible. Hit early, hit hard, and go on hitting for a long time. And the data from Gangaram Hospital suggests that together is better. For example, after myocardial infarction, if you give ezetimibe with high dose of statin, you achieve in 90% the recommendations. With only high dose, you don't reach in majority of the patients and all. But I think important thing is the LDL and all that thing. And as he said about triglycerides, there's a new drug also which is not available in this country. One of my patients has got it from abroad. It can, yes, velonicers. So that is not available in this country, but that has been recommended in these patients which are there and all that. But as he said, the secosopentoic acid actually only recommended for secondary prevention as far as I know. We have used it in the full dosages, 2 grams. They're easily available in this country now.
I don't know. This is actually a highly controversial issue. When Deepak Bhatt published this reduced trial, they had used this icosapentaenoid ethyl 4 gram a day in secondary prevention, and the comparator was mineral oil.
Yeah.
Now people made a lot of hue and cry that mineral oil is toxic to heart, and that is why you are comparing a toxic thing with a neutral drug, and you're showing the benefit. And that is why the Americans gave it a 2B indication, and it has now become a 2A indication.
2A, yeah.
No, 2A now. But
now.
the Americans haven't changed it. It's still 2B. And the reason was they did the strength trial. The strength trial showed that there is absolutely no benefit of icosapentaenoic acid. But then the people said it is not ethyl.
Yeah.
Okay. Then they said, okay, we will measure the serum level of icosapentaenol ethyl. And they showed that with a similar level of icosapentaenol ethyl, the benefit was not there in strength trial, but was there in reduced trial.
I agree it's controversial, but it's a recommendation 2A. So in certain cases,
I think the Europeans have jumped the gun and called it 2A. The Americans still call it 2B.
yeah,
indication.
the reason is there is a benefit of mortality and only secondary prevention at least. Whatever is there, there was a Japanese study which also did not show, but they did not use the ethyl part. You see, that is the another part which is there, but it's available in this country and all that. I think the guidelines about lipids should be very clear to you that in high risk patients, like even in primary, we have primary hypercholesterolemia. My colleague Dr. Sani has done a lot of work. It's not that uncommon. It's found in 15 to 20% of patients who get heart attack below the 41 should try to diagnose this. And the family cascade screening is very important. We have several families now who have their children have very high cholesterol and they are likely to. So it should be treated as early as possible because as the cholesterol load increases, the chances of getting heart attacks increase. Now you can give statins at the age of 8 years also, 6 years also. It's been recommended that patients who have very high heterozygous or even homozygous, of course, needs a little more. You can give this statins at a very young age, and statins are pretty safe. And the lower the better. LDL, if it goes very low, even less than 20, don't bother about it. And then when there is extremely high group, high risk group, which is not included in any other, which is in Indian guidelines. That no Indian guidelines, LPA is very high. Those people who develop, in spite of the ideal LDL, they develop another heart attack. Then they are extremely high risk cases. In them, you should reduce it less than 40 also. So these are in Indian guidelines. So in India, we have extremely high risk patients also. And we should use statins, I think. Unfortunately, statins are not being used properly. And even if they are used, they are not in proper dosages. Thank you very much, I think.
Sir, and I would like to tell the audience that it's disheartening to tell you also. I spoke to Dr. Sani, and about 13 of our consultants in Gangaram Hospital had MI, and out of them, not perhaps 12 were not on LDL goal. Perhaps only one doctor was on LDL goal, and the rest were not even on statins. So, as doctors, all of you have a responsibility to at least get your lipid profiles done and just not listen to the talk, but keep your LDLs in goal. That's very important.
That's not the only thing, you see. The doctors are very unhealthy lifestyle. I don't think exercise, they do exercise. I don't think you don't have stress. You have the most dirty food that you eat. And there was a study done in All India Institute by Dr. Vaseem, my colleague, and he showed that a majority of the faculty members in All India Institute had unhealthy lifestyle and very high cholesterol at that time. So I think we doctors must learn how to be healthy ourselves. And it's a holistic thing. LDL is only one part of it. But I think smoking and other things are also important. And therefore, we should be really healthy, and especially stress management, I believe, should be done because that's it. Any other question? Any question? Yes. Yes, yes. It doesn't matter. It doesn't matter. I have patients in which it has gone to minus, but then you have to do direct LDL. You have to do direct LDL and all this. It doesn't matter. If triglycerides are very high, I think you should do the non-HDL also, which is a co-primary.
3 years 3 years back, actually, there is an Indian cardiologist in USA. Her name is Prakriti Gaba. She compared those who achieved an LDL of 10 milligram with 100 milligram on evolocumab. And there was a 4 years follow-up, 5 years follow-up available. 10 milligram people had 25% reduction in cardiovascular events, but cognition was normal. There were no increased hemorrhagic strokes. There were no muscle issues. None of the issues were.
Yeah, you're right.
One thing is certain, lower the better with no ceiling. So I have 1 milligram. You think I have a problem with that? I have no problem. My LDL is 1 milligram.
You should try to get it. Sometimes you see direct is not done. They were indirectly. But anyhow, I think the lower the better. I think, and there are no side effects of very low. Yes. Peeyush, yes, expert in.
Really, I'm saying.
So I asked my brother who is a cardiologist just now. Does anybody do surgical care like which in US nowadays? He said yes, but only as a part of cardiology.
Correct. Yes,
Yeah.
Base procedure.
In India, base procedure has been done, but results are not very good.
Yeah.
Yeah, only during surgery. Yeah. But this is a new entity which he said, you see, the atrial mitral regurgitation. Atrial ring dilates. We always were talking of the ventricle. This is a new entity, which is the atrial ring dilatation. In those cases, you can do this non-surgical, but surgical is possibly better in those conditions. We don't have much experience of the non-surgical procedures, but in those conditions also, he, I think, quoted that surgery could be done. And at that time, Maze or whatever. Yes, any questions?
I think
If there is none, I think
that's all, sir.
we must thank all the three speakers. They have done outstanding talks were there, and I think our knowledge has been updated quite a bit. I have learned a lot. I am sure all of you have learned quite a bit also. And thank you once again, all of you, for this healthy sort of discussions and all. Thank you very much.
Thank you so much, sir. Just to announce, sir, JC Mohan sir and VK Chopra sir and Peeyush Jain and Manchandana sir, the audience which is attending online is almost 2,496, sir. So that's the people has been waiting up and to hear you like a caliber what you all guys are having it. Thank you so much for wonderful session to the all audience from on behalf of Lloyd Healthcare. Now the bar is been opened, so let's have a drink and a good food. Thank you so much. Good night, everyone.